Good evening, everyone. Welcome. I'm Rich Maritoli and co-chair of the Medical Scientific Advisory Council for the Connecticut chapter. Our chair, Kristine Yaffe, was supposed to be here tonight. Unfortunately, had an urgent issue come up and won't be able to join us. Regrets that she won't be here. It's my pleasure to introduce and to present tonight's esteemed dementia expert, Dr. Kristine Yaffe, who will talk to us about her lifestyle research. Our Medical Scientific Advisory Council in Connecticut has worked hard all year to educate about the disease, help families, and to advance the mission of the Alzheimer's Association. I'd also like to take this opportunity to thank my fellow MSAC members for all they do, as well as the Executive Director of the chapter, Jenny Hanbridge, and our staff partner, Carolyn Duracco. I'd like to share with you that the Connecticut chapter offers a variety of education programs, support groups, 24/7 helpline, care consultations for families, and a variety of services that are funded with your help. And we encourage you to get involved with our Walk to End Alzheimer's Disease this fall. There's 6 walks across Connecticut and hundreds across the nation. Thanks again for helping us serve the 80,000 people in Connecticut with Alzheimer's disease and with their families. This evening, we'll have a brief presentation about association research, followed by Dr. Yaffe's presentation. We'll then have a Q&A period. Please put your questions in the chat or the Q&A, and we'll address them at the end. With that, I'd like to introduce Kristen Cozzato, Communication Director and Research Champion of the Connecticut chapter of the Alzheimer's Association. Kristen?
Thank you very much. Can everyone give me a thumbs up or let me know that they can see that? Perfect. All right. Thank you, everyone, for being here today. We are very excited about this presentation. And I just want to start off just by kind of level setting and give you a little brief overview of what we do, what we fund. So in addition to being the Director of Communications, I am a research champion. There are about 30 of us across the state, staff partners, staff members of the Alzheimer's Association. And what we are not scientists or nurses or doctors, but we are trained and learn about what we are funding, what the direction is, and what's happening in research so that we can share it with you. We can share it with the public, we can share it with our staff members, as well as share it with other folks, board members, various walk committees, etc. So I'll start with this, showing you our symbol, our logo. You may see this on everything that we have, and just to let you know, it looks like you've got a person and a beaker, a brain and a beaker, because it's about people and science. So as we take care of those with dementia, those worried about their brain health, those caregivers, those family members, we are also advancing the science to make sure that we can get closer to new treatments and a cure. I'd also like to share a little bit about what dementia is, dementia Alzheimer's. For those who aren't sure, you sometimes hear those two words used interchangeably. And to let you know, we are the Alzheimer's Association, but we deal with all different types of dementia. So dementia is a syndrome, is essentially the umbrella term of what the person with the disease is experiencing, right? So it's the symptoms that happen. It's the forgetfulness. It's the frustration when you can't remember someone's name. It is the behavior that comes with some of those things. It is the getting lost, coming back from a familiar place. It's having things that you normally know how to use, a pen or something, and not knowing what they do or how to use it. So that is what dementia is, the symptoms they are experiencing. Alzheimer's is part of the brain disease that actually causes dementia. It's a type of the disease. And what happens is we call it, we use Alzheimer's as often because 60 to 80% of those diagnosed with dementia are diagnosed with the Alzheimer's type. Another type is a vascular dementia. Another type is a Lewy body, which I'm personally familiar with. That is what my mom was diagnosed with. Frontotemporal or mixed dementia. So there are various types of dementia. Every March, we have something called the Alzheimer's Facts and Figures that are released. And this is mostly the new stats and what we're focusing on and what we're looking on and just kind of reminding everyone of the status of the disease in this country. And right now, we are at more than 6 million Americans living with Alzheimer's disease. 1 in 3 seniors dies with Alzheimer's or another form of dementia. And some people on this call are caregivers. There are 11 million Americans providing unpaid care right now. We're talking also about this year, what is MCI? MCI, mild cognitive impairment. More than 80% of Americans are not familiar, so we're on a big education push about what that means. Some say it's precursor to Alzheimer's, but not everyone who has MCI goes into Alzheimer's disease. We could learn more about that by checking out alz.org. I want to share a little bit about funding and what happens from the NIH and what happens from us. This is money, that is given to researchers across the country, NIH money. This is not Alzheimer's Association money, but talking about funding and increase in funding over the last 10 years. Back when I was getting involved in this, which was 2010, 2011, we didn't even have $500 million in funding. But because of the folks that you see over to the left, in part, are advocates, we are now at more than $3.5 billion in funding given to researchers at the NIH level. Now, the folks on the left are advocates. What are advocates? They don't have to be politically involved. These folks are literally folks just like you and I, sharing your story with lawmakers, with other legislators, so that when they get on the floor, when they get to the point where they have to make a big decision or make a vote, they'll say, oh, yes, Mrs. Jones from Connecticut talked to me about how hard it was for her to get services for her husband who was diagnosed at a younger age. So it's really about sharing the story. We're very proud of our advocates and all that they've done. On the Alzheimer's Association level, we are the largest nonprofit funder of Alzheimer's and all dementia research in the world. We say that at any given moment, advancements are happening because we fund all over the globe. At present, we've got 920 projects we are funding in 45 countries to the tune of $300 million. And here in Connecticut, which is where we are based, is more than $2 million in Alzheimer's Association funding. And you will hear from one of our grantees in just a moment. But we have folks who are looking at really rare forms of dementia. We have folks who are looking at getting towards a blood test as a diagnostic tool. We have someone looking at apathy or depression and dementia. What is that connection? Looking at it through an MRI lens, looking at it through imaging. And we have some brand new folks who were funded this year. I call them the class of spring of 2022. And one is very exciting because some of these studies, aren't about just drugs. This person is dealing with, he's out of Yale, and he's dealing with kind of the caregiver experience, how caregivers often bring their loved ones with dementia into the ER. How is that experienced? What happens there? What are the resources as they leave? And is there a follow-up? And really in the hopes of reducing the amount of times that you bring your person with Alzheimer's disease back to the ER. So we are going to talk a lot today. Dr. Yaffe is going to talk a lot today about brain health. And this is really, really timely because we are right at the end of June, which is Alzheimer's and Brain Awareness Month. So it's really important to talk about these things. Why not start the summer off with a bang, really making sure that our brains are protected. We at the Alzheimer's Association are funding something called the US Pointer Study. It's very exciting because it's really the first large lifestyle intervention that we're running. It's a 2-year study. We're looking for 2,000 folks between the ages of 60 and 79. You can see that little map up in the corner. There are 5 sites across the country. One is nearby to us in Rhode Island. And we're looking at folks who have suboptimal lifestyles. So perhaps they're coming in with some blood sugar or blood pressure issues. And then we've got this vast program that they're going to get involved with, which includes really important lifestyle issues like exercise, a certain amount of incorporating the mind or Mediterranean diet into what they eat, the cognitive and social stimulation aspect, and then the additional doctors or wellness visits to make sure that blood sugar and blood pressure, et cetera, is up to date. So we are right now at about 1,300 recruited of the 2,000, and 25% are from underrepresented populations, which is very important as our DE&I efforts continue to move forward. Very exciting that we put $35 million into this. The NIA, National Institute of Aging, said we would like to add more to that. So now it's a $100 million study because now they're looking at these folks on these other pointer neuroimaging, pointer ZZZ, as you can imagine what that is, the importance of sleep, pointer neurovascular, and pointer microbiome, the gut-brain connection. So we're going to learn a lot about this, so watch for those. I want to share with you Trial Match. This is a way for folks to get involved in clinical trials, and it's so important that folks from all communities to get involved so they can understand more about this disease. I liken Trial Match to a Match.com for clinical trials. Match.com, for those of you who are in long-term relationships, is a dating site. Don't ask me how I know that, but what you do is you put in your information in Trial Match, your age, where you live, your connection to the disease, and up pops a number of studies that you may qualify for. Here's the key. Your information is never given to them. It's up to you to reach out to a Yale or somewhere else saying, yes, I would like to get involved. So don't worry that your information is given out. But Trial Match and clinical trials are for the, we say, well and unwell, meaning those who have the disease, those who worry about the disease, caregivers, people who don't have any sort of memory issues. There are a lot of different efforts, and we'd love for you to get involved in Trial Match. And of course, presentations like this are really important because it shows you where the money goes that you donate. So we do have 600 walks across the country, and we have 6 right here in Connecticut, as Dr. Maritoli shared. And we would love for you to get involved because the money that you donate goes to not only help us help more families, but also goes to this really key critical research, some of which you'll hear about today. All right, so I am going to stop sharing now, and I'm going to send it to our next presenter in 1 second here. And that would be turning it over to Dr. Carolyn Fredericks. She is a member of our Medical Scientific Advisory Council and also an Alzheimer's Association funded researcher. Dr. Fredericks' research focuses on preclinical Alzheimer's disease and on less common Alzheimer's variants using advanced imaging tools to better understand really how Alzheimer's progresses through the brain. She is a member of Yale's Clinical Neuroscience Imaging Center, a multidisciplinary group applying innovative imaging methods to the study of brain disease. Dr. Fredericks sees patients with a variety of cognitive and behavioral concerns, and she specializes in the diagnosis and treatment of neurodegenerative disorders. So Dr. Fredericks, I'd like to send it over to you.
All right, thank you so much, Kristen, for the lovely introduction. And now it's my turn to introduce the star of the evening, Dr. Yaffe. It is a great pleasure to introduce Dr. Yaffe, who attended Yale University as an undergraduate and the University of Pennsylvania for a medical degree, then completed residencies in both neurology and psychiatry at the University of California, San Francisco. She is now the Scola Endowed Chair and Vice Chair, Professor of Psychiatry, Neurology, and Epidemiology, and the Director of the Center for Population Brain Health there at UCSF. In her research, clinical work, and mentoring, she's directed her efforts towards improving the care of patients with Alzheimer's and other dementias. She is an internationally recognized expert in the epidemiology of dementia and cognitive aging, and serves as the principal investigator of almost a dozen large grants from the NIH, the National Institutes of Health, the Department of Defense, the Veterans Administration, and Foundation Awards. She and her colleagues were the first to determine that potentially 30% of dementia risk, 30%, is preventable. And that's something I'm sure she'll elaborate on in much more detail this evening. She pioneered early investigations on the roles of estrogen, physical activity, and cardiovascular factors in dementia risk. And most recently, her research group has led work on the connections between cognitive aging and traumatic brain injury, sleep disorders, and life course exposures. On a more personal level, I can state from experience that she is a fantastic mentor and a champion of junior investigators. We are so lucky to have her in our field. And my only regret about being able to bring her here so easily through the magic of Zoom is that we don't have the chance to take her out for coffee, maybe at the AAIC. Dr. Yaffe has over 600 peer-reviewed articles dedicated to improving population brain health, and her work has formed the cornerstone for dementia prevention trials worldwide. In recognition of her groundbreaking accomplishments, she received the Potemkin Prize for Alzheimer's Research in 2017 and was elected to the National Academy of Medicine in 2019. So with that, I am honored to introduce Dr. Yaffe.
Thank you so much, Carolyn. It's my real pleasure. Let me see if I can follow that up by actually successfully sharing my screen. Okay. Can somebody give me a thumbs up if that's looking good? All right, excellent. Thank you so much. All right, let me see if I can. Before I get started, I want to, first of all, thank you for this lovely invitation. I can't decide whether it's better or not that we're doing all these virtual things. you know, it enables us to reach far and wide, and we don't have to travel. On the other hand, I really do miss seeing old friends like Carolyn and meeting new friends. I do have a few disclosures. I don't think any of them are relevant for tonight's presentation. I serve on a couple data safety monitoring boards. It's a way for me to stay involved with clinical trials, drug trials, kind of see what's happening. And I'm also a board member of Elector, which is a neuroscience biotech company. Sometimes this works and sometimes this doesn't. Okay, as we all know, we are facing an epidemic in terms of Alzheimer's disease prevalence. This is, of course, because we live longer, much longer than we used to, and also because of the demographic shifts vis-a-vis the baby boomers, et cetera. So right now we're 2022, there are about 6 million, as Kristen told us, 6 million people in the US have Alzheimer's. And if you look at these figures, you can see that in another 25 years, this is going to go up to almost 14 million. So really, this is a critical issue. What do we do? This affects so many people. It affects so many loved ones. And we need to be able to offer people something more than I think what we have now. It's not always advancing. So unfortunately, we don't have any medications that actually prevent dementia. We have a couple of medications that help a little, but nothing that really slows the disease course. Now, recently, as you know, there was a new drug approved after 20 years. It took 20 years to have the FDA come up with a new medication. And as you also probably know, it's somewhat controversial. People are divided over whether they think it really should have been approved. There are some side effects, it's costly. So it's still a little bit iffy. Some people are recommending it. Some people think it's a little premature. I do think we're going to have some really good drugs in the next few years, but so far it's been really a tough nut to crack. Yet many older adults are concerned about dementia. This is an AARP survey from last year, and actually they asked a bunch of people, and it's amazing, but about 50% said yes, they think they will actually get dementia. And another almost 60% said they thought cognitive decline or dementia was inevitable with age. So they didn't think there was really much you could do. So given the landscape right now, with this increasing prevalence and incidence of dementia and lack of really effective drugs, what can we tell people? Is there something we can tell people that they can do right now? And that's what I'm going to really focus my talk on. I'm going to focus on modifiable risk factors. I don't call them all lifestyle because some of these really aren't so much lifestyle. It's really things that I think we can alter, we can prevent. Things like cardiovascular risk factors, physical activity, sleep disorders, and traumatic brain injury. Now, I'm not talking about everything. There are some other ones. We've heard a little bit about nutrition. We've heard a little bit about cognitive stimulation. I'm really focusing on the things that I think have the best evidence, and that's based on both basic science and also the studies that are out there, including trials. The other thing I like about modifiable risk factors is you can really understand much more the mechanisms, what's happening in the brain. For example, with sleep, I'll show you some of this. It tells us a lot about what's going on with Alzheimer's, and I think it offers new ways to maybe intervene. It also is a chance for us to identify those who might be at high risk. You could say, oh, well, these people have these 3 risk factors, and these are the people maybe we should follow more closely. And of course, ultimately, we think it provides some real guidelines of how to prevent and treat. So I'm going to first talk about cardiovascular risk factors, and I'm going to go through those 4 topics that I mentioned and talk a little bit about why we think these are really good things to suggest to patients. What's the mechanism behind them? What's the current status of the evidence, and where do we need to go from here? So cardiovascular risk factors, what am I talking about? Diabetes, obesity, hypertension, high cholesterol, dyslipidemia. We think that these are very important. They affect multiple organ systems. It's not just the heart. We know that they affect pretty much every organ system, but in particular, also the brain. And it's not just for vascular dementia. You heard from Kristen that, chunk of people have vascular dementia. We think these are very important for Alzheimer's disease itself, but also often Alzheimer's is mixed with vascular pathology on the brain. This is some work we did a number of years ago where we showed that having cardiovascular risk factors, in this case, it was the metabolic syndrome or multiple cardiovascular risk factors, that they were associated with much greater likelihood of cognitive decline. And there was an interesting role with inflammation. So if they had inflammation as well, they were even greater risk of having cognitive decline. We've also done some work with midlife. I think midlife cardiovascular disease, people alternate, they say, what's midlife? Well, it's younger than me, right? So it's generally speaking, midlife is 45 to 65, roughly. We did some work with colleagues at Kaiser where we showed that having one of these, either hypertension, diabetes, or high cholesterol, was actually associated with higher risk of dementia 30 years later. So really interesting and I think important for us to be thinking about this, not just late in life, but earlier. And now in this study, which we published a few years ago, we've moved the envelope even earlier. So now we're looking at early adulthood to midlife, and we're finding that even then, having high normal levels of blood pressure, these weren't even hypertension, but high normal levels of glucose or cholesterol, or not so much cholesterol, but blood pressure, really were important in terms of midlife cognitive function. So it's telling us that these cardiovascular risk factors are operating probably across the life course, and it's never too early and never too late to intervene. This is some work by my colleague and friend, Rebecca Gottesman, where she actually showed that ApoE4, which we know is a very important genetic risk factor for Alzheimer's, it's not a dominant, but more like a risk, that there's this interesting interaction with these cardiovascular risk factors and ApoE on having PET scan evidence of amyloid. So another example showing us it's not just vascular disease that's going on, it's also the amyloid deposition, in this case measured by PET scan. So I think very important to understand these cardiovascular risk factors we used to think were just vascular, they actually affect Alzheimer's as well, or at least in this case, amyloid. And this was a very important trial that was published a few years ago called the SPRINT trial. You probably heard of this. This was a large randomized controlled trial that was conducted. And what they did was we were very aggressive with hypertension treatment. Instead of using one cutoff, they were really more aggressive. And lo and behold, after about 7 years, what they found was this intensive treatment actually reduced risk of developing mild cognitive impairment along with dementia. The amount with probable dementia wasn't quite statistically significant, but it was almost. And I think it was because they didn't have enough people developing dementia. So this is very exciting. And I think it's really shifted so that people are being much more aggressive in treating blood pressure in terms of cognitive outcomes now. Where are we in terms of this field? I think most people recognize that cardiovascular risk factors are really important in terms of the risk for dementia, especially at midlife. But as I think I suggested, it's never too early and never too late. We need to use this life course perspective, I call it, much more, because I think it tells us a lot about when you might intervene and what the effect could be downstream. Ultimately, we do need some more trials, but I think at this point, most people do recommend better and careful treatment of cardiovascular risk factors in order to not only improve heart health, but also brain health. So now let's turn to physical and cognitive activity. I say use it or lose it. And you've heard this phrase, meaning be active physically, be active mentally. Why? Well, this was a very old study now, and I keep it in my slides, in my talk, because I just found it so fascinating. What they did was they took a bunch of mice and they looked in the control group. These were just the regular mice that were doing their thing. in their typical cages with their typical amount of activity. And then they had a running group where they actually were exercising much more. And then they had a cognitive enrichment group where they actually had interesting toys and smells and their cages got changed around. And then after a certain amount of time, they sacrificed the animals. And what they found was sort of amazing. What they found was that those mice in the running group or the enriched environment group had greater number of new neurons in the hippocampus. Just kind of mind-blowing. This idea that you can actually change the brain by either being physically active or being cognitively active, I think is just tremendous. And the last 20 years, we've seen a number of studies that have taken off from this in people. And one of the early ones actually was one that we did. And I remember at the time, we almost didn't believe the results. We looked at older women and we looked to see how many blocks they walked. It was very simple. It wasn't a triathlon. It was just walking. And what we found, which was amazing, was that the more people walked, the less decline they had on cognitive testing over a chunk of time, 6 or 7 years. And so we thought, well, is that really true? And we adjusted for everything we could. We adjusted for, their medications and their cardiovascular risk factors and their education. And lo and behold, it really remained. So we were very excited about this. And now, of course, there have been many, many studies looking at physical activity. This was another one that somebody in my group did a few years ago, where she actually did a combination of physical activity and also sedentary behavior. We know a bunch of us are couch potatoes, particularly with COVID. We're sitting down all the time. We're on our screens. So we did this thing where we took a combination of, if you were really active, you were physically active and you weren't on the TV much. We use TV as a measure of sedentary behavior because most people watch TV sitting down. And then we had an intermediate group and then a least active group where they had low physical activity and a lot of TV. And what we found was even in midlife, people actually were doing more poorly on cognitive testing with this kind of profile. So it showed us, again, it's not too late. This is not just something for older folks. This is something for people in early adulthood and midlife. So it's really important. And I think it's important to tell our kids that sitting around and not being active could actually be affecting your brain health. This is some also very interesting work, which looked at people. The top panel, this is a little scientific, but the top people were looking at those with low physical activity on the left panel and high physical activity on the right. And then they divided them up into who had high or low amyloid measured with PET scans, okay? And so what you see is in the high physical activity group on the right, it didn't really matter if they had a lot of amyloid on PET scans. They really didn't decline much on cognitive testing, which is the PAC score. But if they had low physical activity and they had evidence of amyloid on PET scan, they declined on the cognitive testing, just what you would think. And so it's really interesting. It tells us that physical activity may be able to buffer somehow having amyloid even as measured by PET scan. And in the lower panel, this was some work done by a colleague at UCSF, Caitlin Casaletto. And what she did was she studied people with autosomal frontotemporal degenerative disease genes. These are people who eventually will get FTD, but had high or low physical activity. And you can see those are the different, the high is in the pinkish color and the low is in the blue color. And sure enough, even those people who had these genes, it was able to buffer. So I think this is very exciting. It's telling us that even if you're predisposed to the disease because you have amyloid or because you have certain genes, physical activity may be a way to stave off the symptoms or cognitive decline. This is a meta-analysis where you actually combine statistically all the different studies. And these are the studies, these are the trials of people with MCI. You heard from Kristen about mild cognitive impairment. We think of this as sort of a pre-dementia, often on the course of Alzheimer's, but not necessarily. And what this work shows us, which is really in this red diamond, is that if you look at all these trials, that actually it does seem that those MCI trials, when you combine them statistically, do favor exercise as a way to preventing progression of MCI. So again, very exciting. There have been some trials as well in people with dementia or with or primary prevention. So on the left, this was some work from Nicole Lautenschlager, where she actually randomized people with MCI or subjective cognitive complaints, and she found as big an effect actually as donepezil and other cholinesterase inhibitors. However, there was another trial that was published that did not find a benefit. So a little unclear why that large life trial did not show anything. Some people think that people weren't very adherent to exercise. Maybe the measures weren't sensitive. We don't know. But I think it's still somewhat controversial, but most trials suggest that exercise really is a very powerful way to improve cognitive function, prevent decline, and improve MCI. We do, I think, need some more trials in terms of future directions. The other thing is that we haven't gotten very good at figuring out what type of exercise. Does it have to be aerobic? Does it not have to be aerobic? How much? I think these are some of the things we need to turn to now. Right now, people tend to suggest the American Heart Association guidelines, but I do think we need to get a little bit better at figuring out exactly what might work best. Okay, I'm going to now turn to the third factor, third of 4 factors, and this is sleep. This is one of my favorite things to talk about because it is so interesting. Sleep changes as we age. We know that. And this is what this figure shows. As you age, it takes you longer time. In general, these are averages. It takes you a little longer to fall asleep. You might wake up more during the night. Your time sleeping might be less. And we know that the deep sleep, the deeper stages 3 and 4 and REM are decreased. And that's very important because we think those are the stages when actually some of the toxic proteins are cleared out. And I'll show you a little bit of that. So this is really important. We also know with aging, circadian rhythms shift and sleep apnea becomes very common. Sleep apnea, also called sleep disordered breathing. So I'm going to show you a little bit of the evidence linking sleep to dementia. This is basic science, and I think this is just so fascinating. This was published a few years ago showing that when you sleep, and that's the picture on the left versus when you're awake. This is the CSF, the cerebrospinal fluid flow, and you can see when you're sleeping, there's a lot more flow of CSF, we think using the lymphatic system. And it clears out some of the toxins. In this case, it was A beta, but on the right panel, it was also tau. So now we have a better sense. Is this why we spend 1/3 of our life in sleep? You know, maybe it's because it's a time of quiescence when the brain can clear things out and reset the stage for the next day. We started looking at this, gosh, it's amazing. 15 years ago, we started doing some work with sleep, and we showed something that I think is really interesting and now has sort of borne out, and that is there's this bidirectional relationship. What do I mean, a bidirectional relationship? Well, what I mean is cognitive changes, cognitive decline, preclinical Alzheimer's or other dementia seems to be associated with changes in sleep. So that's what the left panel shows you. It shows you that those people who declined on cognitive testing over about 6 years had worse sleep patterns by and large. Not so much the total sleep time, which we'll come back to. It may not be how much you sleep, it's really more how well you sleep. And then on the right panel, what this shows you is the other way, that poor sleep may predict future cognitive decline or dementia. So we call it bidirectional because it's working both ways. And I think this is a very important concept. Preclinical cognitive decline, early dementia is probably affecting some of the sleep centers and affecting your sleep. And we think that poor sleep is then maybe causing greater accumulation of these proteins and therefore leading to greater risk of dementia. Recently, Yu Lang, who's in my group, was able to show in this very clever way. She studied people in the UK Biobank, which is a very large 300,000 participants from UK, United Kingdom. And what she was able to find is that those participants who had a genetic risk score, a high genetic risk score for Alzheimer's, they're predisposed to getting Alzheimer's based on these genes. They don't have dementia yet, but they're likely to develop this in the future. She was able to show in this, using this instrumental variable analysis, that those people had actually a much shorter sleep duration than those without this high genetic risk score. So really interesting, suggesting that these things really go together. And again, it lends evidence to this important role for sleep. And maybe sleep is an early marker for Alzheimer's. We've also done some work, as well as others, with circadian rhythm. Here we showed that if the circadian rhythm timing was off, that there was an increased risk of developing dementia. And Eric Musiek's group has showed again that fragmentation of these circadian rhythms seems to increase the amount of A beta and tau. And also sleep disordered breathing, as I mentioned, sleep apnea. It goes up quite a bit with age. And what we found with sleep disordered breathing, there was an increased risk of developing dementia, as you can see in the yellow bar up top. We think that a lot of this is actually due to hypoxia. When people have sleep disordered breathing or sleep apnea, what do? They actually have these mini times where they're not breathing, they stop breathing, and then they wake up and they breathe again. And we think that it's that lack of oxygen during that phase, which may be what's going on. And the bottom panel here was an interesting study where actually participants were given PAP or CPAP. You know, you've heard of CPAP, that's continuous positive airway pressure. It's a way to help with sleep apnea. And what they found with actually, if the people used the CPAP, there was actually less amount of this hypoxia. And lo and behold, there was less accumulation of A beta. So really interesting. And I think an area we need a lot more information on. So I think sleep is a fantastic area. We need a lot more research on this. We do think that sleep quality is really associated with cognitive function. We haven't had a lot of trials. I think this is an area we need a lot more work. Trials to see whether if you take people and you improve their sleep apnea, you improve their circadian rhythm, maybe you improve the quality of their sleep. I think that may actually be a really important way to prevent dementia, but we don't have those studies yet. My last topic that I want to cover before I try and pull it together somewhat is traumatic brain injury. Traumatic brain injury, TBI. You might say, well, maybe there's not much you can do about having a traumatic brain injury, but I think that's not quite true. You know, you can enforce helmet laws, you can try and change contact sports in a way, or have different rules. In the military, of course, there's a lot of concern about this. And we know that people who have one TBI are often likely to have a second one. So you can do what's called secondary prevention, where you try and have people who've had one not have another one. So this is some work we did a while ago where we showed among veterans that having a TBI increased risk of developing dementia about 60%. And there are meta-analyses. This is a recent meta-analysis that showed again that if you look at all the studies, it was almost exactly the same that we found. There was about a 1.7 increased risk of getting dementia. So it really does seem like it's probably an important risk factor. This is some more recent work where we showed that different severity of TBI matters, but even having a mild TBI, which is considered to be loss of consciousness 30 minutes or less, even that, and even having without loss of consciousness could actually increase risk of dementia. We also think it's important to think of other things. We know that TBI, participants with TBI, patients with TBI often have other things like depression, PTSD, cardiovascular disease, and we think that they may act synergistically. So it's important not just to think about the TBI, but the company it keeps. And this is some work where we looked at biomarkers. We wanted to see what exactly is going on here. Is this due to amyloid? Is this due to tau? What is the mechanism? And to the best of our ability and some other people as well, we don't think it's Alzheimer's so much. We think it may be driven more by inflammation and tau and GFAP changes. We don't think it's so much amyloid. This is some other work that we recently did with Brenda Plasman, where she actually looked at pairs of twins, and she saw identical twins, and she showed that sure enough, TBI is associated with increased risk of dementia, as you can see up here, but it doesn't seem to be so much Alzheimer's. We think it's other forms, either vascular or maybe this thing called CTE, chronic traumatic encephalopathy, that we don't know exactly a lot about, but we think it's really more of an accumulation of tau and inflammation and probably vascular changes as well. So I think most people think TBI is an important risk factor. We do need to get a lot better trying to understand the mechanisms. The blood biomarkers are a godsend for all kinds of things. I think it's going to show us a lot more what is going on in terms of what this association is. And I think we need to start screening people with TBI and following them more closely to see whether how things progress and whether this link with TBI with dementia is actually due to CTE, which to date has really just been a pathologic diagnosis. So we don't know exactly what it is in life. I now want to switch gears, and I think Carolyn sort of alluded a little bit to this. We did a study a number of years ago where we wanted to see, okay, there are these different risk factors that we think are important. What if you put them all together? What if you could move the needle and you could look at these things and change all of them slightly? What would your bang for your buck be in terms of downstream? So we looked at these things, and this was before I was doing a lot with TBI. There weren't a lot of great studies out on sleep yet. So we focused mostly on the cardiovascular things, which are here. We looked at physical activity or inactivity. We looked at education, which is sort of a proxy for cognitive stimulation. We looked at depression and smoking. And what we did was we tried to figure out how common are these things and how much of the disease could they maybe explain. And then we put them together in this chart on this figure on the left. And what we found was when we adjusted for how much they co-occur, it led us to believe that about 30% of dementia could be explained by these modifiable risk factors. So a lot of this is genetic, a lot of this is bad luck, but we thought that maybe about a third could actually be prevented if we were able to actually move and reduce these risk factors. And that's what the right panel shows. This shows you that if you could, you're not even asking people to stop smoking, you're asking them to stop 20% in red or 10% in blue. And what you can see when you put all these things together, everybody exercises 10 or 20% more. They smoke less, you know, et cetera. You can see you actually could have a big downstream effect in terms of Alzheimer's prevention and the lowering of the prevalence. So this was very exciting. And we thought, wow, you know, we could really have a public health impact. It may not be a one-to-one in terms of one person, but in terms of public health, this could have a big impact. And lo and behold, a number of studies that have come out. It's really complicated to explain. It was really sort of off message, but a number of studies started coming out where they took in the same study, the same cohort, and they did dementia ascertainment over a decade or two. And you can see here 5 of the studies. So one was the HRS, one was in the UK, one was the Rotterdam study in Netherlands, one was the Kungsholmen study in Sweden, one was the Framingham study that you probably have heard about. And what they found was sort of amazing, which was if you looked within the study, not the whole population, but within the study, that it seemed that the dementia prevalence was actually going down. And most of these studies, I didn't do one of these studies, but most of these were attributed to the fact that things have changed over time. We've gotten much better at cardiovascular disease control. Our education system, by and large, has gotten better in terms of who's getting educated, et cetera. And so that's what they thought this was due to. And then more recently, some colleagues did the same thing where they actually looked at some of these studies, but added some other ones. And they showed the same thing. They showed that there's a 13% decline in incidence per decade over the last couple decades. So this is a little off message because I showed you in the beginning, We know that the prevalence is going to go up and that more and more people are going to get Alzheimer's and other dementias. But we think that there was something interesting happening over those decades that may have decreased the amount of dementia slightly, 13%. And we think that it probably has to do with these secular trends of like I said, better cardiovascular management. This is when statins were introduced during those decades. We think that education and economic well-being may have had a big effect. However, I'm very concerned because, as you know, this is a period now where we're more sedentary. There's a lot of obesity and diabetes. And I worry that these trends for reducing, these public health trends for reducing incidence are probably going to go away. So where are we in terms of public health? What can we tell people? Now, a few years ago, it was sort of really interesting. 2 reports came out at the same time by very august groups. One was the National Academy of Sciences, Engineering, and Medicine, NASEM. I was privileged to serve on this committee. But the committee took a very strict view. What they said is, you know, we really want only big randomized control trials because that's the gold standard. We don't want to look at observational studies or animal models. We want to know what is it in these big trials. And, you know, there weren't that many trials. The trials had to be at least 500 people. They had to be followed for at least 6 months. And at the end of the day, there wasn't that much that was definitive. But there were 3 things that the committee felt looked really good. And that was cognitive training, being active, you being stimulating cognitively, intellectually, blood pressure management, which I showed you in terms of sprint, and being physically active. But the committee said, you know, we need more work. At the same time, I'm telling you, the exact same month, another report came out, and that was from the Lancet Commission. And that's another very august body. And they said, hey, no, there's 9 risk factors. They all look really good. And it's time for us to be ambitious about prevention. And this was very confusing because how could 2 bodies of, you know, smart people come up with sort of different answers? And I think it was really because the National Academy relied only on large randomized control trials. And the Lancet Commission said, no, we're going to look at all of the evidence and our opinions, and we'll look at observational studies. So it's a little confusing. I wrote an editorial and I actually thought, you know what, there's a really important message here, which is we need to inform the public that cognition and dementia risk are also modifiable and they're susceptible to the effects of many cardiovascular and metabolic factors. And this idea that the brain actually can grow and change, even in late life, is really powerful. And I think that that's a very important message. You know, when I was in medical school, we were taught you were born with a certain number of neurons, and every time you hit your head or you had a glass of wine, you would kill a couple thousand. And it was sort of a depressing idea. But now we know that that's probably not the case, that the brain continues to be plastic, continue to grow. I showed, that's why I love those animal studies, those rodent models with the physical and intellectual activity, because you can form new neurons. It's a little controversial still in people, but we think that the brain can change the synapses and grow. And it's really not something just to throw your hands up and not think there's anything you can do. So I think it's a very important public health message. And then around this time also, the finger trial came. The finger trial was a multi-domain trial. They included nutrition, physical activity, cognitive stimulation, and cardiovascular reduction, some of the things we've been talking about. And what they showed was over 2 years, there was a reduction in the group that was randomized to the intervention as opposed to the control arm. The control arm, you can see, is in blue, and the intervention is in red. And what they found is on 3 of the 4 cognitive tests, the intervention group did better. So this is very exciting. We don't know whether this actually means dementia will be prevented, but actually it looked like the cognitive performance on these tests was much better. So that's very exciting. And as you heard from Kristine, this has now stimulated a number of trials. We call it worldwide fingers. In the US, it's called Pointer, US Pointer. And you can see in the dark blue, these are all the studies that actually are conducting trials, which is pretty exciting. And in the light blue, these are the ones that are planning to do trials. So for example, there's going to be one in South America. There's going to be one in Canada that's actually underway. There's one in India, et cetera. So very exciting. And I think we'll really learn a lot more about whether these modifiable risk factors, well, in this case, it's those 4, whether they could actually have an effect. So I think it's super exciting. We also are in the middle. I'm leading a trial that is a smaller trial. It's more of a pilot trial, but it's the same concept. We're taking people who have risk factors. They're 70 years or older. They have, they're concerned about their memory or cognition, and they have to have at least 2 risk factors. And we're randomizing them to this intervention where they get counseling on certain things. We worked with their primary physician. We're trying to target cardiovascular risk factors. You can see down here, sleep, diet, depression, medications that might not be helpful. And we're looking at a number of outcomes. So we're just finishing this study, and I'm very excited. Hopefully we'll be able to look at this data pretty soon. What are the next steps for prevention? And then I'm going to conclude and be open to hearing your questions. I think that at this point, it's really an exciting time. We're seeing all these trials now in the US and worldwide. One problem, though, we've mostly been studying white older adults in the US and in other high-income countries. I do think we need to get much better at looking at diverse populations. You heard that US Pointer is trying to enroll 25% who are non-white, and I think that's fantastic. We, in our SMART trial, it's about 20% as well. I also think we need to understand more low and middle income countries because they have different risk factors. Low and middle income countries, people are less likely to be sedentary, but maybe the education's not as good, or there's more smoking. So we may need to tailor some of these to the actual different countries. And this is some work we recently published in JAMA a few months ago, where we actually looked at disparities in dementia. This is in older veterans, and we were able to look in almost 2 million veterans. We had 5 different race and ethnic groups. And what we found was pretty much what we expected, which was compared to whites, which is in this, the low line here, in particular, Hispanics and Blacks had much greater likelihood of developing dementia, about a 2-fold increased risk. So we really need to do better at understanding why is that? And one idea, by the way, there wasn't so much Asian and we also had looked at American Indian, Alaskan Native. These groups were slightly increased, but not so much. One of the hypotheses is that the reason we're seeing this much greater incidence of dementia in the non-whites is related to risk factors. So that maybe there's different risk factor profile. And this is some work from a colleague who worked with us recently and showed exactly that. Looking at these modifiable risk factors, and you can see the list of them on the x-axis, that they differ by race and ethnicity. So it may be that in certain people, you want to target depression or obesity. And in other people, you might want to work on education or physical activity. And some of that's driven by individuals, but some of it may be driven by income and by race and ethnicity, because as we know, there's certain cultures that may have certain diets or certain genetic risk for certain diseases. So I think this is very exciting. And I think this is one of the next pushes we're going to make in terms of prevention. So where are we? This is my last slide before I mention some of my contributors. I think it's a very exciting time in the field. We think there are several promising strategies for decreasing risk of developing dementia, and they're low cost. These are they're not expensive by and large. We don't think there's a lot of side effects. So I think they're things that we really want to offer our patients, either alone or in combination. It's still somewhat controversial, and in particular, we have a lot of questions still on the quality of the evidence and whether actually, say, for example, with sleep, whether sleep actually could prevent if you improve sleep. We still don't know a lot about everything. The other concept that I think is extremely important is this idea of life course, that it's never too late, but it's never too early, and that that we tend to study dementia. Dementia is a disease of old age. So we tend to study people when they're 70s and 80s, but yet everything that's happened in their life might be contributing to their brain health. We shouldn't just be studying these risk factors when people are 70s and 80s. We need to be studying them across the life. We need more of these randomized controlled trials, and we need to understand much more in terms of diverse population, whether these strategies work the same, whether certain things may be more or less important to target. My goal and my prediction is that ultimately Alzheimer's and other dementias will be somewhat similar to cardiovascular disease, where we will have a cocktail of drugs. We'll have a drug for tau. We'll have a drug for amyloid, maybe a drug for inflammation. And we also will have modifiable risk strategies, and they will be managed together. Too often people want to look at drugs only or prevention with modifiable risk strategies only. We need to bring them together and treat them just like we do cardiovascular disease. So with that, I just want to thank some of the funding that I have, primarily from the NIH and from the Department of Defense and the VA, and also thank my team. This is the Center for Population Brain Health that I direct, and we have a lot of fun, and I look forward to now hearing from you and hopefully answering any questions. I'm gonna stop share and go there. Okay.
Thank you so much, Dr. Yaffe. Fascinating. So much to talk about and a lot of questions, a lot of wondering to go into a little bit deeper on some of the things that you talked about.
Sure.
You know, in talking about inflammation, which you just mentioned, we might as well start there. You know, thoughts on studies about caffeine and more studies about inflammation and how we can, you know, how that will help if we can control that inside our bodies.
Yeah, great question. You know, inflammation is important. Again, it's sort of like cardiovascular disease. It affects everything. So inflammation is we think is bad for heart. It's bad for, you know, your arthritis. It's bad for gut, kidneys, etc. But also we think inflammation is harmful for brain health. It was something that was studied for a while ago, 20 years ago, was something that people spent a lot of effort looking at. And then there were some trials with non-steroidal anti-inflammatory drugs, or NSAIDs, and the NSAIDs didn't seem to work. And I think the field sort of took a step backwards for a while, but now people are getting much more interested in it because I think it's becoming clear that inflammation has a very important role in dementia etiology. And it's not clear, you know, does it cause it or is it reactive? Probably doesn't matter. It's very important. And I think it's an area that's now, as I said, now getting a lot more attention. Are there things we can do about it? I think some of the work with the microbiome and the gut-brain axis, a lot of that's focusing on inflammation. Some of the genetic risks may be related to inflammatory pathways. So I think it's an area we're going to learn a lot more about.
Someone was asking about your thoughts on gene therapy.
That is not something that I am as familiar with, gene therapy. Some colleagues at UCSF are starting to look at this. I think it's an area of great promise, but it's very, very early in the days. And the things that work best for gene therapy often are when there's a one clear gene that seems to be related to the outcome. And particularly if it's a known gene where you can change it. There's a big piece in the New York Times today about CRISPR and gene editing. And so I think it's a fantastically interesting field. We have to first make a lot of progress with the diseases that I think we understand their genetic basis much more, and they're maybe simpler. The problem with Alzheimer's, as you know, it's very complicated genetically. There are some rare families where it's an autosomal dominant pattern with clearly one gene that could be targeted. But with your average Alzheimer's, it's not like that. It's really probably 100 genes that are interplaying with one another. Some might be protective, some might be risk. That's going to be much harder harder to approach. But I think my prediction is in the next 5 or 10 years, we're going to start seeing people trying to really target those rare families with the autosomal dominant pathways. And if there's traction there, then that would be really, really exciting. Because as you know, those people tend to get Alzheimer's much younger, 40s, 50s. And so I think it would really be fantastic.
Those families, but they're so amazing to be putting themselves through so much, to try to help.
Absolutely.
These are families who, they have 2 children, and 50% of your children are going to have this disease, right? So
that's right.
Yeah. So let's talk about that also. Someone was asking about studies about being bilingual, multilingual, helping in reducing risk.
Mm-hmm. The issue of bilingualism, or a colleague of mine at UCSF, Marilu she's very complicated Italian name, Marilu Gorno Tempini. She is an expert at language and dementia. She studies FTD a lot because there's often a language component. She's been doing some work with colleagues at bilingualism. It does look like bilingualism is often a way, there are different centers in the brain that may be affected. And it's an area I think that's receiving now a lot of interesting attention. People do talk about it also from the point of view of learning a language. So there's the being bilingual, does that help you stave off dementia? I'm not sure we know that yet. It does look like there may be different patterns in terms of developing dementia, with those people. The other question, I guess, is, are we stimulating our brain? So if you take up Italian, which I clearly need to do, and you take up Italian when you're later in life, does that then stimulate neurons and make connections? We think so. We don't know for sure, but this idea of being cognitively active, I think, is very important. It doesn't have to be, I tell my patients, you don't have to play bridge. If you don't like bridge, don't play bridge. Do something that you like, that you're going to stick with, that you feel like you're learning.
A couple of questions in the Q&A. One of them is, how long for all the new drugs to target specific types of dementia? When will they be available? She and her husband are in their early 70s with family history of dementia.
Well, I wish I had that crystal ball. For a long time, everybody said, oh, it'll be 5 or 10 years. Oh, it'll be 5 or 10 years. And I showed you at the beginning, it's been 20 years since the FDA had approved a new drug. I do think the pace is going to pick up quite a bit. And for a long time, for all those 20 years, most of drug development was primarily focused on amyloid pathways. This idea was that it was amyloid, and therefore, how can you block the accumulation of amyloid? How can you get rid of the amyloid? And I think people now think that it's more complicated than that. It's not just one pathway. Tau plays a very important role. Some people think you have to have both amyloid and tau. That's what the evidence suggests. The role of inflammation. Some people are now getting very interested in the immune system, in particular, the role of microglia. So microglia are not neurons, but they support the brain and they support health. We think maybe it has to do something with immune regulation. So there's I'd say the positive thing of all the failures over the 20 years is that now people are really saying, wait a second, we need to start and look more deeply and understand that the brain and Alzheimer's and other dementias are not so simple. The downside, of course, is that it's taking a long time. And a lot of drug companies have said, you know what, this is too hard. We've spent so much money, we don't want to keep investigating this. So it's a mixed bag, but I am optimistic. I think we are onto some new paths and some new strategies that actually will really work out. And I do think we're getting much closer. There are a number of studies now with tau. There's a number of studies with immune regulation. So I think we're in a whole new chapter in terms of drug discovery.
And I think just knowing that, the FDA did approve the one, albeit controversial, there are many others in the pipeline. It's not something that you just
That's
start
right.
now. It's not that something doesn't work and then you start now. It's been happening for a number of years. It takes 15 years.
Well, and the other thing that's really exciting about the FDA decision, even though it's controversial, the idea of using biomarkers, I think, is going to revolutionize the pace of drug discovery. So it used to be that you had to, everybody had to have a PET scan, and everybody had to, and it was very costly and it took a lot of time. These blood biomarkers are going to really be helpful, because you can use these to see whether the drug you're studying is having any benefit. And if it's not having any benefit in terms of changing the biomarkers, then you might say, okay, let's not do a 2-year trial. Let's save all that effort and our money to look at something that's actually moving these biomarkers. So I think the pace of drug discovery is going to just exponentially increase by using the biomarkers.
Yeah, excellent. Questions about hormone replacement therapy and statins and their risk factors.
So you heard maybe a little bit from Carolyn that was one of the things that I started my career studying estrogen and hormone replacement therapy. And there was a lot of good evidence. I mean, this is why the National Academy said, hey, we're just going to limit our evidence to big trials, because we've been burned. There have been in lots of fields times where we thought, based on the animal data, based on the observational studies, we thought something looked really good, and then it was in a trial and it didn't bear out. And that's what happened with hormone therapy. It looked really good. People thought it was the best thing to prevent dementia and Alzheimer's. And then there were a number of trials, in particular the Women's Health Initiative, which showed that no, it didn't prevent dementia. In fact, in some cases, it increased risk. So it really shut down the field. Now people are starting to understand, well, it may be more complicated. And in that trial, people were started later in life. Maybe it's different around menopause. Maybe it had to do with the preparation of the hormone. So I still think it's a little unclear, but by and large, people are not pursuing that very actively, because I think it didn't really bear out. Same thing happened with statins. So statins looked really promising, and there were a number of trials, both for MCI and for prevention, and they did not bear out. I am not aware of much work in that area anymore. I think it was a little, both of those were really frustrating, because they looked really promising and then they didn't bear out. So that was another thing that was happening at the same time that drug discovery for amyloid was not working, and nothing seemed to be working. So I think it really set the field back. But again, I think with these multi-domain approaches, I think we're going to get a lot more traction.
Question about sleep aids and dementia. I know a couple studies came out a couple of years ago. Where do you stand on that?
Oh, wow. That is it's actually a question I get a lot, and I never quite know how to answer it, because I don't think we have the evidence. We know that people who take sedative hypnotics, sleep aids, particularly things with Benadryl or other benzodiazepines, things that we don't think are good for the brain, that's probably not a good strategy. It might be helpful for one night, but you don't want to be taking those long-term, particularly if you're older and you have some cognitive concerns. Those are drugs you really don't want to be on. And you have to look at the over-the-counter labels very closely, because, Tylenol PM, it has Benadryl and diphenhydramine. So you have to be careful. We don't know if you're a poor sleeper, is it better to take, one of these drugs that might help you sleep? That's not the sedative hypnotics, but specifically for sleep. There are all these orexin antagonist drugs now. There's these other classes of drugs, the Ambiens of the world. We don't know. It's a really interesting question. would they help you, or are they harmful? Most people say take them for a short term because we just don't know. But it's a really good question, because is it better to get better sleep, or are these drugs messing you up? We don't know.
Everything in moderation, it seems.
Everything in moderation. That old adage does probably bear out in a lot of ways.
Yeah. Going back to head injuries, question about concussions. First, you could talk about maybe head injuries in kids, maybe, or males and females. And then also someone said something about thoughts on people exercising shortly after a concussion to get the blood flow. Is that something that you're hearing about?
So I'm not a TBI expert. I mean, I'm really a dementia expert, and I try and study things that I think are really interesting and we can learn about, and we can learn about what's happening in the brain, and we can learn about maybe ways to prevent. So I'm hardly a TBI expert, so I don't want to, act like I know more than I know. I'd say it's a very important area. There are people who are really concussion experts. The people who have acute TBI tend to see either neurosurgeons if it's a bad TBI, or they tend to see rehab specialists. I'm really interested in TBI as sort of this long-term effect and how it interplays with dementia. So that's really my area. I do think that the field is moving very quickly. And I think there's some wonderful things happening in terms of kids, in terms of guidelines to understand what a concussion is. And there's now pretty good protocols in place for kids in contact sports. You may disagree with them. We don't know if they work or not, but I'd say that we've come a long way, and that at least we have those protocols. Most kids know what a concussion is now. And I think that's really important, understanding what it is, and that maybe it's not the best thing to go right away. I don't know about, I can tell you, you don't want, if you had a concussion, you don't want to go back in the game, so to speak, where you could have another concussion. So that's really a lot of the issue but what we're understanding is that you probably don't have to rest quite as much as we thought. But again, I am not a concussion expert or TBI expert in terms of the acute injury. So I would refer you to somebody else. And I'd be happy to tell you some of those people.
Talking about a general percentage risk factor from a parent inherited, right? My mother had it, my father had it. What is my, risk factor? There are questions about that.
Yeah. So we know, I mentioned before, that there's sort of two flavors of genetics vis-a-vis Alzheimer's disease. And the rare families that have autosomal dominant, where if you get the gene, you will get the disease. And half the kids will get the disease because it's chances, everybody has two sets of genes. So it's since it's autosomal dominant, you got a 50% chance of passing it to your kids. So that's different though. Those are rare families. And in that case, if you get the gene, you will get the disease. And there's some rare families for frontotemporal dementia as well, where it operates a similar way. Most dementias are not that way. Most dementias, in terms of particularly Alzheimer's, vascular, Lewy body, they don't operate on that sort of one-to-one. It's more a risk. And we think that if a first-degree relative has Alzheimer's or dementia, that is a risk for the first-degree relative. A lot of that's because of ApoE4, we think. So ApoE4 is the most known genetic risk factor. Again, it's not a one-to-one, but if people have one of the E4 alleles, they probably have about a doubling risk of having dementia. If they have two, it's a much higher likelihood of getting dementia. Depends a little bit on the age and some other things that I won't go into, but that's what's driving a lot of the risk factor genetic inheritance in terms of the non-dominant Alzheimer's disease.
Then we suggest if you do need to find out that, and you do need to go to find out, don't just do one of those things you buy on the internet. Please go through a genetic counselor so that you can talk to them about it afterwards. And just willy-nilly send your blood over to find out what's going on. We really,
such a good point. Some of these genetic marketing strategies are not always as good as they say, and there's not counseling, and it can be very scary. And I think if it's something that people want, Yale has an excellent program, and a lot of universities have great programs where you can actually first learn about this and then hear sort of the benefits and risks of finding out. And one has to be careful too, because there's some downsides of finding out, both in terms of psychological information, but also, being careful in terms of health insurance and et cetera. So it's something you have to think very carefully about and get some expert advice.
But we also know that changes can happen in your brain up to 20 years before any sort of symptoms occur, right? So starting, as you said, it's never too late to start. It's never too early to start to do some of the things. Just a couple more questions. Question about seizure disorder or epilepsy risk.
Sure. You guys are coming up with some good questions. That's another very complicated area. It's really interesting, but one of my colleagues at UCSF, Leonard Mucke, who's a fantastic basic scientist, he thinks that part of what's happening in Alzheimer's preclinically, so early, is that parts of the brain are actually hyperexcitable, that they actually are showing some epileptiform activity. And some people think that may be some of the early changes. Is it compensatory because some of the neurons are dying or not working as well, and therefore some areas of the brain are acting more? Is it more neurochemical? We don't know. But some people think that this hyperexcitability or proclivity to get epilepsy might actually be part of the pathway. Other people don't think that's the case, but it does seem that we did a study a number of years ago, where we looked to see people who had a seizure for the first time later in life. And it wasn't because they had a stroke or they had a head trauma or metabolic or anything like that. They had a first-time seizure later in life. They didn't have epilepsy their whole life. They just had a seizure, and there was no evidence of anything else explaining it. We did find that there was an increased risk of developing dementia in those people. So I think it's an area we need a lot more research in, but it's really interesting. And I think if you have talked to Dr. Mucke, he would say that's because this is sort of an early sign of Alzheimer's starting. So almost more like a prodrome than a risk factor, but I'm not sure we know.
Okay. Questions about trials, and we've put a couple answers in there about getting involved in trial match and other sorts of things. Most studies for older adults, but there are some studies for folks that are in their 40s and 50s, right?
Sure, there are. Yes, right. And I think we're going to see more of that. I think as people start understanding that these life course factors are so important, the problem is we don't know whether they should be the same level. So for example, you might, if somebody's 30 and they have high blood pressure, what do you, or high normal blood pressure, are you supposed to treat them? How aggressively? How long? We just don't. So there's a lot of questions that I think we have to answer, particularly around drugs. Now, physical activity, I could say physical activity, diet, sleep, these are things that you would want to be doing all the time. So I think so it really depends on what it is.
Someone did ask about diet. I know we talk about the Mind and Mediterranean diet quite a bit.
Yeah. Sure. Yeah, I don't, sometimes it depends on what talk I'm giving or what's going on. Sometimes I include diet, and because I think it is a field that's really getting a lot of traction. It's not so simple. What we think about diet is that it's not a single nutrient. We think that it's not one vitamin or one thing, but it's really more the pattern. So we think it's really more like the MIND diet or the Mediterranean diet. It's the pattern that you're eating. It's not one nutrition. It's not blueberries. You know, blueberries are not going to do it. You've got to really, I think, look at your whole diet, and diets that tend to have less red meat, more leafy vegetables, more whole grains, more olive oil, less processed food. The other thing is we're thinking more and more that, you know, multivitamins might be helpful. Again, it's not one vitamin, it's the package. So sort of treating everything as sort of a healthy diet, healthy supplement. But a lot of people take a lot of supplements, and a lot of them are expensive, and they really haven't been studied. So I had a teacher who once said that Americans have the most expensive urine, because a lot of these have not been shown, and you know, they probably aren't harmful, but they're probably not beneficial. Most.
Another thing that please go check with your doctor before you go spend $400 a month on
Absolutely.
something that promises to give you.
And if you're missing that nutrient, for example, B12, some of the B vitamins, if you're low in that, absolutely, replacing those are really important, and something that everybody should be doing.
But some supplement that's marketed to keep your brain sharp, just please be wary. Always check that out. All right, we are kind of approaching the end. I'm going to kick it back to Dr. Maritoli. Thank you so much, Dr. Yaffe, for a wonderful presentation.
Excellent note to close on there. Thanks, Dr. Yaffe, for a wonderful discussion and presentation. Very helpful and very thorough going through all. We really appreciate your time and energy for that, and sharing your research with us. For those of you in the audience, just a reminder that the event was recorded and will be available and sent to all those who registered. Also, there is a section on the website of the Alzheimer's Association devoted to research, so we encourage you to check that out and look for recent information. Also, there'll be an upcoming Alzheimer's Association International Conference in San Diego this summer. So there'll be a lot of great research news coming out from that sort of the end of July, beginning of August. So again, keep your eyes open for that. Thank you all for coming. Thank you again, Dr. Yaffe. And for everyone, have a great night. Thank you.